Hi, this is Ayesha Akhtar with the Epilepsy Foundation of Greater Chicago. And with me today, I have Dr. Rebecca Garcia Sosa. She is an attending at the Lurie Children's Hospital, as well as an assistant professor at the Feinberg School of Medicine with Northwestern University. So thank you, Dr. Garcia, for being with me today.
Of course. Hello, everyone. As she said, I'm one of the neurologists and epileptologists at Lurie Children's, and I'm here to answer some questions and be of help if I can.
Awesome, thank you. And one of the main reasons why I wanted to have you on today is your presentation on rescue medications that I attended about a year ago, actually at the Northwestern Symposium. I loved it. I think you did a great job explaining rescue medications, and that's kind of what I want you to do today. So let's start by kind of just defining rescue medications and talking about what it is, who qualifies for rescue med, and how to use it.
So rescue medications are meant ideally to stop seizures, to either stop prolonged seizures or what we call clusters of seizures or acute repetitive seizures, which are used kind of interchangeably. When we talk about prolonged seizures, we talk about seizures that are going longer than 5 minutes, because we know that seizures that go longer than 5 minutes are less likely to stop on their own. Acute repetitive seizures or clusters of seizures have been defined many different ways in the literature, and it can be very different from patient to patient, whether it's a child or an adult, and what type of epilepsy you have. It can look very different. So it could be you have 3 seizures in an hour, or that could be that someone that had been seizure-free for 6 months all of a sudden had like 5 seizures in a week. And so it's very variable. In general, it's meant for more for several seizures in an hour or in the course of 24, 48 hours. But as I said, it depends on the patient and the type of epilepsy a kid or adult has.
So as we know in the world of antibiotics, abusing antibiotics leads to sort of like the uselessness of antibiotics over a period of time. So can you kind of talk about rescue medications in that same way? Like how often should families be using them?
Ideally, we try to control, well, when we give rescue medications, if we find ourselves giving too many, we end up adjusting some of the daily medications because we can't use them, like you said, every day. When is it safe to give again? We tell some kids, if the child is still seizing at 10 minutes, 15 minutes, and the child is awake and there's no respiratory distress, you can repeat the drug or you can repeat the rescue drug at that time. Sometimes we can say you could do it twice in the 24-hour period. It depends on how they tolerate it, but that can vary. If you get to that point, you probably should be talking to a physician. You should be getting advice. We never advise to doing these things without letting us know, because when you get past that point, you definitely worry that you may get too much somnolence or you may have some respiratory depression and things like that. So they're not meant for everyday use. We use them if we need to, and we use them to try and avoid admissions to the hospital, unnecessary hospitalizations, reduce cost if possible, and to try and keep children and adults at home as much as we can if we can reduce the seizures or even reduce the severity or the frequency.
Using the rescue medication, it can either, abort a seizure or just to reduce the severity of it. And I think that does give a peace of mind to the teachers to know that this is there for them in the event of an emergency as a rescue medication to kind of mitigate that entire length of the seizure, as you said. Yeah. So let's talk a little bit about the different types. There's multiple administrations, and as you know, you're smiling. The FDA finally approved a new method last year in 2019 in May. I think right around the time you gave your talk. Can you walk us through the different types of rescue medication?
Yeah, so until 2019, or I should say early 2019, which is last year, the only option we had that was actually FDA approved was rectal diazepam. And it was based on 2 randomized controlled trials that were done in 1998 that compared them to placebo. And it definitely showed a reduction in seizure frequency. It showed that that rectal diazepam was safe and that it was good for stopping seizures and for global outcomes in general. For patients to give, it was safe, all of these things. After that, some of us, including myself, we were using intranasal midazolam, and we had our own techniques and ways to give that because we felt like rectal diazepam was not just feasible for everyone. It's a little harder to administer if you're overweight or if you're wheelchair bound or you have mobility issues, or if you're an adolescent and you're in the middle of prom or whatever that may be. So we were using things like intranasal midazolam with some, however we could with it, so with some education and how to do it, but it was a little bit cumbersome. And finally in 2019, intranasal midazolam in the form of nasalem got approved, which is really easy to use and really easy to give. And we can use that now in children over the age of 12, and it's been officially approved for that. In addition to that, Valtoco, which is intranasal diazepam, a little later, got approved as well. And that can also be used in children above the age of 6. And so now we have 3 options, which is really nice to offer families. And it depends on the situation, it depends on the patient, on the size, on the weight, all these things, what's more feasible or what's more doable for each family. But definitely having more options has become much nicer to offer families. That whenever we used to say the only thing we have is Diastat or rectal diazepam, would be like, we have to give a rectal medication, which is something that is definitely hard and conceptually hard, even though it's easy to give, because administering is easy. But I think having more options has been really, really nice.
That's good. So then it gives another sort of peace of mind for families to know that they don't have to feel stuck with Diastat, because as I'm sure we've talked about before, I know I've told you that conversation in the classroom with teachers is often where the conversation gets stuck. And I try to encourage teachers to be able to kind of get past that and to know that it's just an emergency situation, as you said, to prevent the prolonged seizure or when you're handling a cluster of seizures.
Yeah,
Are
and
there,
actually, until it wasn't FDA approved, some schools were not wanting to do intranasal midazolam, even though it was prescribed by physicians. Now that it is, it's much nicer to have more options for them, and for those that don't feel comfortable giving it rectal medication, of course. Yeah, so it's been really nice.
and are you able to talk about maybe anything that's kind of in the pipeline? I know that there are sublingual, maybe some buccal trials out there. Are you able to talk about any of those?
Yeah, so there's a so buccal midazolam, which is just a different type of administration of the same drug, is actually approved in Europe. It's not approved here yet. There are other options of things like oral clonazepam or lorazepam or diazepam that we can give tablets. And in the case of clonazepam, it can be really handy because it dissolves in the mouth. So even if someone is having multiple seizures in a row, you could put it in the mouth and it dissolves. And those are things that maybe don't work as well as the other 3 I mentioned, but they can work in reducing more acute repetitive seizures than, I would say, a prolonged convulsion. And we use these things differently depending on the patient. I think I've said that before, and I said that in the lecture, that there's not one size fits all. It's not like that. I encourage everyone to talk to their physician about this. What are our options? What if we encounter this situation? If we get to this point, what are the options and what we should do? And there should be this is step 1, 2, 3, and if this doesn't work, what to do next and next and next, so that you never find yourself in, oh my God, what do I do now? Which, if that's the case, you call 911, but I think that everyone should have a plan in place. But interestingly, there is a trial about on intrapulmonary alprazolam. It's another type of benzodiazepine, and it actually just finished a phase 2b trial, and it'll be starting phase 3 trial later this year, if not started yet. And it's meant to go straight to your lungs. It's through normal breathing, and so you put the device in the patient's mouth, and with normal breathing, it reaches the lungs. The absorption is really, really quick. So it's supposed to be even quicker than the other ways or devices we have. And so that's kind of the next thing we're looking forward to. At our hospital, we talk about it, then our nurses come in, we always have devices with us and we show how to use them. All of these devices are really easy to use. And so while it sounds very stressful, they're made so that you don't have to think much. Anyone can give this, and it's really easy to administer. So it's much easier than it sounds like, and it's less stressful when you actually have to do it, because it helps that you just have to push and it goes through, both for the rectal diazepam gel as much as the other intranasal forms. And so I think that's very reassuring. Once they can see and practice with it, it just, oh, okay, anyone can do this. This is good. And so showing exactly what you're talking about can be really helpful. So I find that families really like that. And there's also online videos and like teaching online that can be really helpful. So I encourage to look at those when there's questions or concerns.
Administering a rescue medication is actually covered under the Good Samaritan Act of Illinois. So a person who in good faith tries to administer a rescue medication to someone having a seizure, they can't be fined, they can't be sued, no harm can come to them because they are in good faith acting as a Good Samaritan. So that's another great thing that we've actually incorporated that into our Seizure Smart School Act, which will go into effect July 1.
Yeah.
Is there anything else in the world of rescue medication that we haven't talked about today? Anything else that you would like to share?
No, I think I couldn't stress enough that when in doubt, talk to your physician, talk to your doctors, talk to the nurses in the office, and ask what the options are. And not everything works for everyone. I give the example of children with that are super immunocompromised, whether it's because they're in chemotherapy or whatever that may be, shouldn't probably get rectal diazepam. So even though they are under the age, maybe it's a 5-year-old, maybe it's an 8-year-old, you should talk about other options because rectal diazepam may put you at higher risk of infection if your immune system is not good. So I think all these things need to be discussed, and they need to be discussed at every visit. Also because patients grow, and this is not a one dose for your life. It changes as you grow. And I do pediatric epilepsy, so we look at that all the time, and in adults it may be different, but I think it's important to know that every time you go to the doctor, you need to revisit that because your dose may be expired, it may be old, it may be, or it may be that now there's a new form and we want to try that instead.
That's wonderful. Yes, you're right. You stress definitely consulting with your physician, and also just the importance of making sure you check the expiration date. I've had that situation in schools a lot where someone wants to go use it and they see that the diastat is expired, and then they're concerned about how to dispose of that. So that's definitely a great talking point for sure. Well, I just want to thank you so much for being with me today and for answering all these great questions, and I look forward to seeing you in person.
Absolutely, you're welcome.